Well, great to invite everybody to virtual grand rounds. We're hopefully going to get this back in a live form at some time in the new year, but not quite yet. We want to thank our five cranial faculty for participating in today's event, and definitely thank our industry sponsors. We do this for both spine and cranial. Each of us have a Grand Rounds Day, and it's definitely through our industry relationships and that we're able to move technologies forward. So I'm really looking forward to hearing everybody's talk. First up is Dr. Bobby Stark.
Thanks so much. Thanks so much again, Dr. Levy, Dr. Marcos, the rest of the faculty, and then also all the companies that help support our patients and our research. And briefly today, I'll be talking about technology developments in cerebral aneurysms. So here's my funding and disclosures. Our research lab is supported by a lot of grants as well as by company support. I think most of you know my training, and I put this up here mainly for one reason, that the year that I did in New Zealand and Auckland was a really tremendous year, in part because they're so far ahead of us in testing devices, because it's so much easier to get things forward and into the hands of physicians. So even at that time, we did one of the first web cases, which the trial, the U.S. trial for web was just finished. But a lot of these other things, we're either just getting here or we still haven't gotten here. And so it's a really long process to get these devices and things approved. And so it's helpful to be able to test a lot of these things as we do in the lab before they actually make it into humans. So certainly my wife would tell you that I became a complete tool at some point in my training, but really I think part of that is just so that you have all the tools at your fingertips for all the correct situations, so that if you just have a hammer, everything looks like a nail, even if it's a rabbit. And you put those two things together, and sometimes you end up with a lot of nails in your head. So we'll talk about, so one of the reasons that I did all this training is I didn't know I was going to have such great partners from such varied disciplines and backgrounds to support me when I came here. I think we do see some unique things in Miami, and we'll go through some cases and some of the new technologies today. So this was a 23-year-old medical student complained of severe headache while studying. She collapsed. She was transferred here. It took a while for her to get here. By then, she was had minimal brainstem reflexes and already had some ischemic changes. And despite her probably likely poor outcome, we treated this sort of fusiform, wide-based pericallosal aneurysm with microsurgical clipping. And she still went on to make really an amazing recovery over the next 6 months. So I think some of our older, technologies are still very, very, very useful, and we really need to continue to count on these, even though there hasn't necessarily been as many advances in some of the microsurgical techniques and some of the clips and things that we've been using for a very, very long time. So I think our main modalities are open microsurgical. Some of my other colleagues will talk a little bit more about that today. Not to leave that out, there have been advances in microsurgical techniques that are extremely important and have allowed us to make our job easier and easier. Mostly I'll be talking about endovascular techniques today, but still microsurgery plays an extremely important part. For example, this patient with these 3 small aneurysms of the middle cerebral artery, this through a very tiny, this is a 2-inch craniotomy, we're able to clip all those aneurysms. And I still think that that's probably the best treatment modality for this patient, who basically went home the next day with a Band-Aid. You can see his incision there. Another patient with a history of coiling, you can see this recurrence at the bottom of the aneurysm, this ACOM, and through a tiny eyebrow incision, this is about a 1-inch orbitozygomatic craniotomy, we're able to clip this. So some of our oldest techniques are still extremely important. Something like this massive aneurysm, 6 centimeters, was treated with a radial bypass, and then we removed this whole aneurysm with clip reconstruction. So these If this was my brain at the end of a case, I think I'd be a little bit disappointed, even though this patient went on to make an incredible recovery. But anytime I think we can get there through a less invasive fashion, but achieve similar efficacy with similar complication rates, I think certainly that's the right approach. Not always possible. This giant aneurysm was treated with coiling 7 times at another institution, presented with a second rupture into the ventricle. You can see here the blood. They noticed that the femoral arteries were both occluded, and then they transferred the patient here. We did a radial angiogram. You can see this massive blowout. There's a fetal PCOM, so we still don't have a great treatment modality for this patient. And ultimately, we removed all the coils and we did this clip reconstruction of the vessel. But there has to be better alternative therapies. I mean, we can't still be doing these same techniques in 5, 10, 30 years. I think it would be a great disservice to our patient. And that's part of the reason that we work hard in the lab, and also these companies work hard to try and come up with new technology. And even this review, which we wrote, I think we published this a couple of years ago, is already antiquated in many ways. So this is my lab, or this is our lab at the BRB. I'd urge all of you to come by for a visit. We've got biplane angiography next to MRI. We put in a CT scanner, ultrasound, numerous operating rooms, and this is really all just for research. So I think it's important to know where we came from before we talk about new technology. I mean, we could spend literally days talking about this, so I'm going to skip through this fairly quickly. But some of the first endovascular techniques were started in 1941. In 1991, Guglielmi and Cogli brought forth the detachable coil, which was a major breakthrough. And then after that, you start seeing this explosion up to 2012, the first stent retrievers. But since then, it would take pages and pages and pages to go through all the developments that have happened since then. So these things are, really every other day we have a new product or something new to test or try. So some of the major advances that really briefly I'm going to touch on today are imaging, treatment, and very briefly medical therapy. So imaging, these are all new techniques that have been developing fairly quickly that help us in aneurysm treatment. So 3D imaging is something that can be carried out with CT, MRI, or in the angiography suite, and really help us plan treatment for these difficult cases, as well as get a better understanding of which lesions are at high risk for bleeding. 4D imaging allows us to quantify things like flow, resistance, shear stress, and various other factors that are really still being used primarily in a research standpoint, but may be able to better help us with planning of cases and also defining which cases are high risk for causing problems. MRI Nova is a non-invasive technique that actually allows us to quantify the amount of flow and the direction. So it's not just velocity, but the number of cc's that are traveling through a particular vessel. And this is particularly helpful for things like bypass, but also understanding complex anatomy when certain vessels are narrow or occluded. Various new techniques to improve our imaging, like this is a dual energy CTA with bone windows. You can see here, this is our old CTA. This is looking at the stent, and you really can't see contrast through the stent. But with this dual energy, thin cut, bony CT algorithm, you can see that actually this stent does have contrast going through it, and potentially that could save a patient the need for an angiogram. Microangiography, this is really something that hasn't made its way to patients yet, but I have no doubt that in the future we'll be able to see down to almost the subcapillary level as far as vessels. Confocal imaging is something that we use in the lab a lot that hasn't made it into MRI, CT, or angiography, but I think in the future we'll be able to actually stain and identify particular cells. This is newer confocal imaging that allows up to 7 slices. So this is really tremendous, versus the confocal imaging that we had many years ago where we could maybe do 1, 2, or 3 slices. But here we can identify numerous different types of cells. Intravascular imaging is something that's developing extremely quickly, and it's being used in cardiology, but this is intravascular ultrasound or intravascular optical coherence tomography. This is actually a microcatheter that's placed inside the vessel that using a laser will take an image. And you can see here the stent tines This is something that I just ran in the model. And you can see that here, the stentines are not perfectly opposed to the vessel. And we published a fairly recent paper in Stroke looking at OCT for cerebrovascular imaging, which I think could be a major advance in our field so that we can see inside the vessel better. Molecular imaging, this is something that we're working in the lab using different stains and markers to look at. This is an aneurysm that has increased uptake of staining significant for macrophages, which may signify a more unstable aneurysm. So I think molecular imaging and then also antibody imaging, where we can actually look at particular molecular markers and see that in imaging, would help us identify potentially unstable aneurysms or those that are more likely to rupture. Endovascular devices, I mean, we could spend days talking about new endovascular devices. Briefly, I'll try and touch on all these different areas with the time that we have left. So improved microcatheters are definitely making our job easier and easier. They're more slinky, they're longer, they track better. This is using a dual microcatheter technique to coil a wide-based aneurysm. And by weaving the coils with two microcatheters, we can lock coils into place and potentially avoid a stent or a balloon. Balloon has a disadvantage of it requires temporary occlusion of the parent vessel, and stents require aspirin and Plavix. So sometimes we can get by with a dual microcatheter technique without the necessity of a balloon or a stent. And we've published a number of papers on this. A number of companies are coming out with now steerable microcatheters. So using this wheel here, you can actually change the tip of the microcatheter in 180 degrees and then lock it into place, which will allow us to navigate more difficult or challenging anatomy. Improved catheters have really played a tremendous part in our treatment of aneurysms and stroke. Numerous companies now developed much better catheters. Stryker, they might briefly touch on their Infinity today. Balt, the Ballast, Penumbra, the BMX. These are really improved large bore catheters, and these have allowed us to treat aneurysms that we previously weren't able to treat with microsurgical techniques. I think Eric will briefly talk about his new catheter, but we're testing a tremendous number of catheters both in the lab, and we're using a lot of these new catheters in patients, and that's allowed us to treat these aneurysms more easily that we couldn't previously get to. And it's also allowed this sort of, with many other advances, this radial explosion. And we're doing most of these our cases through a radial approach now. We've had numerous publications on this, looking at new catheters, new sizes, new techniques, tortuous anatomy, and how to sort of achieve better outcomes with these better catheters. This was our recent publication comparing this multi-center study that we headed up, comparing radial versus femoral approaches for flow diversion, and we saw a decrease in access site complications and also overall complications. We were able to pool all these cases together. This was a study of about 2,500 patients that received flow diversion, showing that flow diversion through a radial approach was associated with decreased complications. This was another recent paper that we had looking at bilateral transradial access for complex aneurysms, and I think that's a much bigger approach. We're also using liquid embolic agents for some aneurysms. Unfortunately, this is not developed as far as we as we would like. So liquid embolic agents, we've tried to use them for aneurysms. For liquid embolic agents, we're mostly using these for mycotic or traumatic aneurysms, but we're testing some of these things in the lab going forward. So we've got a lot of liquid embolic agents. Some of these have been available for many years, but we've got some new ones like Phil and Squid and some other ones. And now we're moving forward to testing a number of embolic agents in the laboratory that are not available, and I can't talk about those yet. But the benefit is that potentially we could fill up aneurysms and leave less dead space. So that would be a major advance, versus coils where we might leave some dead space. Larger diameter coils have been developed by companies like Penumbra, larger, longer, thinner coils by Target, and also by Balt. And these coils allow us to take up more volume and can potentially be cost savings, radiation saving, and time saving. So I'm not going to talk too much about those today, But this was a case, this giant aneurysm, we're able to do a bypass and then sacrifice both of the vertebral arteries. This is 3 to 4 coils, and this took about 5 minutes versus in the past where we might need tremendous number of coils. Bioactive coils, we'll skip this today, but there have been many trials looking at bioactive coils that might take up better space. So far, these randomized clinical trials haven't shown a major benefit. But I think bioactive coils will in the future be able to diffusion. The Medina is another sort of flower structure that's coming along. And again, this would be able to take up more of a complex shape to fill coils. You can see this here in a model. But this still hasn't made it to humans yet. So balloons, another device that's really advancing tremendously, that's an adjunctive technology that can help treat wide-necked aneurysms. You can see here using 1 or even 2 balloons. And the benefit is this can hold coils into place. Stents. I think I'm frozen here, but we'll skip that. Many new advances in stents and types of stents. So everything from tiny, thin stents all the way through to high metal coverage, thick covered stents. So we've got thin stents like nitinol hypotubes, and the original Solitaire, which we still use for mechanical thrombectomy, was actually developed for aneurysms. And when I was in New Zealand, we frequently detached the Solitaire for aneurysm coiling and for many other complex cases. After that, we had things like the Neuroform and the Enterprise, and we've looked at many we've had many publications on stents looking at these things in aneurysms. We've already moved sort of past this and are even probably pretty rarely using this stent going forward. The Atlas has been a major improvement in stents. It goes through a much smaller microcatheter and it's much more trackable. The Elvis Jr., another stent which has more metal coverage, is another one that we use on a regular basis for stent-assisted coiling. And many of these stents can now go through a balloon, like the Scepter balloon, so that you can coil, use a balloon, and place a stent all through the same microcatheter potentially. Flow diversion has been another revolutionary technology. You can see here this aneurysm before, after. This aneurysm before and after has allowed us to treat many of these impossible aneurysms. And we've had many studies now and longer term outcome, especially on the first generation flow diverting stents, but we're still waiting for longer term outcomes in many of the newer ones. And we've had sort of an explosion of publications looking at this through radial approaches and other methodology, as we talked about before. Many of these stents are now looking towards newer generations. We've had the Flex, which is the second generation of pipeline now, since we did one of the first cases in New Zealand. So many, many, many years. But now we've shown that as you use these stents more, your techniques get better and better. We're looking at many modifications to the surfaces. This is the shield modification for Pipeline Flex. And we did one of the first couple patients using FDA exemption in the United States for this, but it has a potentially less thrombogenic coating. And we've tested this extensively in the lab in large in vivo models. This is one of the first patients that we did. This was one of the publications that we had recently looking actually at the 4th generation pipeline, the Vantage, with this new surface modification, which is less thrombogenic and allows for better healing, improved endothelial cell attachment, and less thrombus formation. So people are starting to look at using these stents with single antiplatelets, and I think in the future we'll probably eventually get to a stent where you only need aspirin instead of dual antiplatelets, and likely a ways in the future where we have a surface modification that doesn't even need antiplatelets. So we're testing this in a number of clinical trials going forward at the moment. They have also used this to develop much, much larger stents. So stents that are trackable that can get to a more difficult anatomy. Stryker, maybe they'll touch on this further today, but the Surpass stent was their flow diverting stent, which also they made a larger model of this. And moving forward, we now have the Surpass Evolve, which is more flexible and easier to get to more distal anatomy. The Fred by Microvention, another one, a flow diverting stent, also comes in smaller sizes. and allows us to get to more distal anatomy. But now we really have a tremendous number of flow diverting stents, and it seems like almost daily we're testing a new one of these stents that has different abilities. You know, some of these major advances will be they will be able to go through much smaller microcatheters. So like the Silk Vista Baby, there's a large trial coming to the United States hopefully this year, and that goes through a much smaller microcatheter. It's careful, you know, we need to carefully evaluate these technologies. New technologies lead to new complications, things that we had really never seen before. This was a case of a giant aneurysm treated at another hospital where the stent actually got stuck in the aneurysm. And this is another similar case like that these cases required microsurgical treatments for successful treatment of the aneurysms and these occluded stents. So we need to keep up our microsurgical skills. It's not that we can just forget that. This is another similar case. So wide-necked aneurysms, I think I'm running out of time. So briefly, you know, this was a case we used to use either clipping or Y stent coiling. Now we're using a lot of adjunct devices like balloons. The web device or intrasaccular device is another option, which actually doesn't require treatment of the parent vessel and doesn't necessarily require aspirin or Plavix. And a number of companies have developed a number of alternatives to web that they're still working on, will probably be in the market soon enough. We have a lot of devices to help hold coils in place that are coming along. We contribute to the NAPA trial. This is the Pulse Rider. And this is sort of a T-shaped device that has less metal that can help hold coils in place. Now we've really seen an explosion of these types of devices like the Barrel, the Eclipse device, and then you've got all these other adjunctive devices that can help hold coils in place. You know, I'll skip some of these today. This is the Contour, the Comanche. So happy to have all of you guys or anyone that's interested come by and visit the lab. You know, we're working a lot of technologies, and part of that is because our current knowledge of biology is inadequate, and a better understanding would lead to improved patient selection and non-invasive therapy. So we're looking at the pathophysiology of cerebral aneurysm, moving that towards medical therapy, imaging, and treatment options. This is many of the many models we use: aneurysms, stroke, embolic agents, and large in vivo models to look at new surface modifications, drug reservoirs, anti-mediated stent cellular calorie.
What's the deal? You guys moving soon now? Yeah, he's so far it's great.
Moving forward, looking at some of our new stents that we're testing that are imaging, better technologies, medical therapies for better treatment options for our patients. So in conclusion, endovascular therapies develop at a tremendous rate. Their better models are necessary, and we're working on many of those in the lab. We'll have novel imaging for diagnosis, risk assessment, and planning, intraprocedural treatment and follow-up. Devices can improve our treatment abilities and outcome, but they can also lead to novel complications, and we need to come up with better retreatment strategies to solve these problems. We need to be careful that development can outpace clinical trials, and that requires continued need for well-designed research studies. So thanks very much. I know that was a bit of a blast, but I think we kept to the short time period that we had. Thanks so much. And any questions? So maybe I think Jose, you know, we tried to intermix our talks with some of the companies. So I have most of the major companies that are supporting us, you know, give a brief talk in between the talks. And I think we've got a number of companies today. I'll introduce Jose, kind of introduce the next talk, but I think he was going to talk briefly next, or maybe if Dr. Levy wanted to introduce her, he had some words to add. Thanks so much.
That's awesome, Bobby. I think, is it Dr. Caballero or Jose Caballero? And then I know Dr. Marcos is up soon after.
Thank you, Dr. Levy. Thank you, Dr. Stark. So good morning, everyone. Thank you for the opportunity to speak today. Penumbra is proud to sponsor this important meeting for the 4th consecutive year since its inception, and I thank UMH and the physicians involved for the invitation. Well, Dr. Stark, as you all heard, talked about, the exciting technology coming through the pipeline, a burst of new activity. Today, I'll be specifically talking about one of those new technologies, something that the physicians were essentially the first ones in the world to do first in patient cases, which have gone exceptionally well. And that product is the Benchmark X96 delivery guide catheter. It can be used for a variety of interventions, including to treat strokes, aneurysms, AVMs, and fistulas. So briefly, to review, Penumbra has a history of innovation. For mechanical thrombectomy, as you may know, the technology began with small aspiration catheters and separators to break up the clot. And for access, Penumbra developed some of the first catheters specific to the neurovasculature. Starting in 2013, Penumbra developed new technology and released what continues to be best-in-class guide and thrombectomy catheters. And now, late last year, Penumbra once again released a new groundbreaking technology, the Benchmark X96 guide catheter, which is lovingly referred to as BMX, is how I'll refer to it mostly throughout this presentation. So BMX is a guide catheter or standalone long sheath that has the largest inner diameter of any 8 French guide catheter. It provides smoother access, more support than any other 8 French guide catheter. So high level, the change from the standard previous 0.088, industry standard, is a 19% increase now to 0.096 inch. And Penumbra did that without increasing the OD. It actually slightly decreases, so it remains an 8 French sheath. So Penumbra, how did Penumbra do that? So we were able to do that using a completely new catheter construction technology. Instead of using the braided wires, as I'm sure many of you are familiar with, Penumbra used a single stainless steel hypotube and laser cut that thousands of times per catheter. So the result was achieving the larger ID while slightly decreasing the outer diameter. Here's a look at the catheter, and here's a magnified look. And what you can see, if you look carefully, notice that some parts have different cuts than others. So essentially with these different cuts, different size cuts, different quantity of cuts, it makes the catheter more supportive where you would want it to be supportive and more flexible where that's needed. And essentially the Benchmark X BMX has over 1,000 transition zones, when historically when we talk about catheters, like guide catheters, we say it's got 4, 8, 10, 12 transition zones. This has over 1,000 transition zones. So in addition to the new tech, BMX has other design features that you would want and expect in a guide catheter. It's got a full length PTFE liner, platinum radiopaque marker bands, and a hydrophilic coating on the distal 11 centimeter segment, which the company did a lot of testing. We found that 11 centimeters was the optimal balance for trackability and stability. It comes pre-packaged with a dilator, and also, and so this is a close-up view. If you look here, these are close-up views of different catheters, and here you can really appreciate the difference in the construction. You can see in the bottom a braided catheter. The ballast has a different technology, and then you can see the BMX on top, which looks radically different. One thing that we wanted to do is, a lot of times physicians want to go to a direct stick, and we made sure that the ledge protrusion between the dilator sheath and the actual distal tip of the catheter was as minimal as possible. And you can see that there in this image, it is a very small ledge protrusion. In fact, the dilator sheath takes up 99% of the inner part of this catheter when it's inserted. Of course, these catheters have to be soft at the tip, and we made sure that at the tip, Benchmark X is very soft and atraumatic. That is also helps with trackability. And then the biggest thing that comes out of all this new technology, the biggest change is the support. Once you get this catheter to where it needs to get to, the support that Benchmark X provides is astounding. And this is extremely important. So as Dr. Stark reviewed all those new technologies that are coming in the pipeline, a lot of those systems are increasingly heavier. And the last thing you want when doing a procedure is you've taken all this time to get to the target lesion, and your guide system is falling down or kinking, etc. The BMX has so far consistently shown that it can support all these new systems, including dual therapy. So more than one microcatheter or guide catheter through the system. Here's the one video I'll show, kind of the culmination of all those technologies that I described. When you think about, the cases that these catheters really shine, and you really want something stable, supportive, trackable, this is a good example. You know, here we're compressing the catheter, and you can see how far it gets, and that bend does not kink. And again, we have seen these in the cases that Dr. Peterson, Yavagal, and Stark have done. We have seen that BMX has so far not kinked and performed exceptionally well. So, you know, pretty short and sweet. Look, in conclusion, the BMX 96 catheter represents, you know, another big leap in neuroendovascular technology. I mean, the Jackson team has in their hands, you know, one of those, you know, leading technologies right now that's come out around the world. And if physicians are able to take up those heavy systems, the flow diverters, the webs, et cetera, get them to the target area without worrying about their catheter falling out. And that large inner diameter, the 0.096 inch, you know, it allows physicians to put a lot of different options on what they want to put up. You know, before with 0.088, there might be some catheters that just didn't fit, or you couldn't get good contrast runs, but this larger inner diameter allows for a lot of different options. Definitely the most options that physicians have ever had in getting up into the brain. And of course, you know, like I mentioned, this UMH team has been leading the way in the world in using this catheter. Have a lot of physicians reach out and ask, you know, for tips and tricks, and they're very excited. So I thank the physicians for for being at the forefront of new technology as usual. Thanks. Thank you, everyone.
So thank you very much. Actually, next is Eric Peterson. So I'll introduce my partner, Eric, to speak.
So my talk really centers around some of the kind of general high-level themes that I've learned is the journey that I've had in the last couple of years on the company that I started and sold. And a lot of people ask me about this. So I think there's so much to cover here, but I think on a symposium about innovation, I think it's interesting to kind of go through what's on the back end of some of these innovations that people are coming up with, and really geared towards what is the role of the physician in this ecosystem. And my main point here, of course, is going to be that our role should be the dominant one. We shouldn't be the ones where someone comes to us 5 years later and says, "Hey, here you go, you're welcome." We should be the ones from the beginning making it for a whole bunch of reasons, mostly for our patients. And so I have this organized into 6 tricks that I feel are helpful for a physician looking to understand the innovative ecosystem and how to add value there. Trick number 1 is that, you as the physician should be the one to do this, right? Not someone else. It should be you. There is this ridiculous mantra out there about, I can't do that. I'm just a surgeon, or I'm just this or that. Those guys are geniuses, or they're smart and I'm not. That is complete nonsense, right? The fear of making something stupid or failing blocks 95% of people with really good ideas from even starting. They just are too afraid to even start, right? It says, oh, someone smart can do this, but I can't. I would really argue that the exact opposite is true, right? We have an obligation to build things. Don't just coast along on what others have created. Add to the pie. You have really unique domain expertise, and it's a really unique opportunity for you to do it and not have someone else be doing it. I hope this video plays. I've played this a couple of times, but I think it's a great way of understanding how to think about this problem. Let me know if the sound is working.
Yes, we heard it.
When you grow up, you tend to get told that the world is the way it is, and your life is just to live your life inside the world. Try not to bash into the walls too much. Try to have a nice family life. Have fun. Save a little money. But life, that's a very limited life. Life can be much broader once you discover one simple fact. And that is, everything around you that you call life was made up by people that were no smarter than you. And you can change it. You can influence it. You can build your own things that other people can use. And the minute that you understand that you can poke life and actually something will, if you push in, something will pop out the other side, that you can change it, you can mold it. That's maybe the most important thing.
So I love that quote because it really gives a lot of empowerment to quote normal Steve Jobs, Elon Musk's of the world to be able to do things. And I would argue that as physicians, particularly neurosurgeons, we're way off the curve. We already have a pretty big advantage on training and domain expertise and unique skill sets, and of course intellectual horsepower. So I would encourage all of you, just from a starting point, to realize that this isn't get past that initial, I can't do this. You can be the one to make all this stuff up. The trick number 2, open your eyes to what else is going on around you, right? Once you really start paying attention to all of the problems and how the world is done, particularly in the hospital and healthcare ecosystem, you realize that we're just surrounded with problems, right? Terrible products, bad processes, terrible workflows that are super inefficient. People always ask, how do you come up with an idea? Or they complain, oh, it's amazing that so-and-so thought of that. But those people are not any smarter than you or I guarantee it, right? But their eyes are open. Like, those people are paying attention to a world in a different way. Their whole world mindset is different. They don't actively look. They just pay attention through the lens of, how could this be improved? How could I make something better? How can somebody fix this problem? And once you start kind of walking through life like that, you don't have to like go come up with an idea. You're actually literally bombarded on a daily basis with things that can be done better. In fact, I've noticed that once you're switched on in this way, it really becomes more about which problem are you going to choose to solve, right? And this is really the first step that most people just go around their day accepting the circumstances. I'm not talking about striving to improve yourself. I'm talking about just accepting how things are done each day. And you really have to start viewing the world through this lens of, there's a better way to do this, and I could be the one to maybe figure this out. And once you do think about it that way, you're going to think of all sorts of ideas. And then the next question really comes down to, how do you choose? And that's a really important question, right? You can sink years into chasing an idea. It's really critical that you actually think through this. And one of the big traps of academia is overvaluing some invention or idea or patent, right? Innovation is not invention, right? It's important, but that's not enough, right? True innovation has to be commercialized, right? It has to be figured out a way to get that thing to market. And so you have to think through, will someone actually pay for this? Will a lot of people pay for this? Who exactly would pay for this? Otherwise, your idea and your invention is just going to collect dust somewhere, and no patient's ever going to be helped by it. And often the true innovators aren't the ones that invented the actual technology, right? Steve Jobs didn't invent the computer or the technology that underlies an iPhone, but he's a genius in packaging the technology into a product that could be commercialized. And it's the same thing with Elon Musk. He didn't even found the company, Tesla. He was introduced to the company and then fell in love with the technology and the idea, and then essentially self-funded it on his own, so much that he kind of became the de facto founder, but he wasn't the inventor. He just commercialized it. And Steve Jobs and Elon Musk, those are true innovators, right? So it doesn't mean the technology isn't important. It is. In fact, one of the key skills, I think, is in using a new technology in a way that no one has really thought of. But the majority of technologies, patents, et cetera, don't really solve a real problem that people have. So the technology itself doesn't have much value. It's much harder to focus on a technology and then try to find a problem to solve with it. But unfortunately, that's what a lot of people in academia do. They get all excited about some research and technology of theirs, and they try to then say, okay, how can I make money off this? And that's really tough. Finding a technology looking for a problem to solve is really not the way to look at things. Instead, focus on the problems first, like we talked about earlier, and then figure out which ones of these problems can be solved with your skill set, and which ones are actually worth solving from a market perspective. Trick number 4 is think about what the world is going to look like in 5 years, not now. Think about what it's going to look like in 5 to 10 years and build to that world, right? And so when you have to break out of this current impression of how the world works now, because people tend to default into, okay, well, this is just how things are done, and they become much less imaginative because they don't have any idea of how the world could be. They're so limited by what they see in front of them. And it's actually tough to do, at least I found it very tough, but you have to work on understanding what world the current technology can enable, and then build to that. And that's really tough for physicians. Physicians are notoriously narrow-minded. Formal education, especially medical education, actively discourages independent thinking. We are trained to follow protocol and be conservative, and that makes us particularly unimaginative. You'd be amazed at how bad physicians are when asked about the future at predicting things. Most of us in general are terrible at predicting how our future selves are going to behave. If you lots of studies where if you talk about how people are what movie you're gonna watch in the future, we always overweight how honorable and how impressive our picture is gonna be. We don't choose the shoot 'em up movie, but and when it comes time to actually choose, that we're actually totally different. But if you think about the future, what does it look like in your field? What can you build now that will have value in that future? And so why is it so important to be able to think independently and not just do what everyone else is doing or think what everyone else is thinking? Well, this is one of these things that I've shown a couple times before, but in order to succeed and get something that really takes off, you have to be not just right? You can't build something for the future and have it be wrong. Obviously, if you think, I think in the future, flying cars are going to be the thing and you're wrong, then you're not going to win. Obviously, you have to be right. But it's not enough to be right. You have to be right and non-consensus, meaning if you're right about the future, but everyone else also thinks that, then there's gonna be 100 people doing the exact same thing, right? And all those little advantages are gonna get arbitraged away and you're not gonna be able to build anything valuable. So you have to fundamentally think about, what is it that no one else sees? What is it about the future that you believe in that you don't think anybody else is really paying attention to or even knows, right? And we as physicians have a unique advantage here, right? No one is going to know a lot of the things that we know, right? If you're like, I think machine learning is going to be big. Yeah, of course it is, right? You may be right, but tons of people are going to build for that future and you're not going to be able to build anything unique there. Trick number 5, unique domain expertise, like having a real expertise in a specific area, plus focusing on being able to innovate and what the process is like, that is the sweet spot, right? This is our unfair advantage as specialists, right? There's tons of MBA types that would kill to know what everyone in this room knows about neurosurgery and the healthcare system more broadly. They just don't know. So it's very, very difficult for them to create real innovation. But the opposite is true for us. We think we can't start a company and we can't do any real innovating because we don't know how to do that. So we don't do it either, right? So there's this gap. But the truth is the company stuff is actually pretty easy, right? A few days on Google, learning about startups and company forming and getting some advice and you're there. But the innovation part is much harder. Coming up with something that people want and will pay for at scale is much harder. But for those like us that are in the trenches being bombarded with inefficiencies and crap products on a daily basis, it's much easier, right? That goes back to that earlier trick we talked about. Once you start paying attention to this sort of stuff, as long as you're switched into the idea that any problem that I see, there's at least some chance that I could be the one to solve it. I just have to figure it out. Then you're really into a really nice place where there's lots of these opportunities. And when you think about a lot of these opportunities, a lot of them result from technology that isn't intuitively obvious to be applied to the certain solution that you're talking about. And as people that are sitting in academia with all these technologies, you're in a really unique position to think about a unique way that some technology that you come across could be used to solve a problem that maybe only you are paying attention to. So when you see some new cool technology or you're faced with some problem, think about like, what is it that you know of that can solve this? And just keep thinking that way. Eventually you'll connect the dots in a way that no one else has. And then last, think about the market, right? You have to think about how big this could be. And as a neurosurgeon, it's inherently a smaller market. So you have to think clearly about what realistically could I build with this that people would want to pay for at scale, right? If you have some amazing new technology that allows you to really clip basal-tip aneurysms better, that has no future, right? Even if the technology is amazing, even if you get past the whole, let's go back to opening up people's skulls to treat aneurysms thing, there's just aren't very many people running around with basal-tip aneurysms, right? It doesn't matter how good your solution is, how good your patent is, the idea is going to go nowhere, right? The market is probably the most important thing to think through when you're thinking of an idea, and you really need hard data for this. People ask me like, hey, what do you think about this? And I say, how many people have that problem? How many patients in the US every year have that specific problem? And what subset of those patients have this specific thing that can be addressed by your technology? And they don't even know. They spend all this time thinking about their IP and their patent, and they have no idea how many people actually have this problem. That's super, super important to think through. And that's it. This is my boy yesterday. He learned how to tie his shoes. Super exciting.
Thanks, Eric. Who's speaking on behalf? Who's next from the industry?
I believe it's Endo. I believe it's Endo, Omar.
Are you online? Ingrid Menendez, are you on? Who did you have slotted
Yes,
to follow?
Iggy, can you play the video for
Understood. Got it.
Striker? Yes.
All right.
Thank you.
I was a legal secretary for many, many years, and some of the hobbies included backpacking, camping, fishing, canoeing, anything to do with nature. I was out of the shower getting dressed, and I was on my way to an appointment. And next thing I know, I woke up in ICU. I had a ruptured aneurysm in my brain. Pretty much if my husband hadn't have been home, or if he had been outside mowing the lawn, he wouldn't have heard the thud when I hit the floor, and I wouldn't be here today. It was scary.
So Ruth came with what we call a bleed inside the brain. It's a subarachnoid hemorrhage, and most of the subarachnoid hemorrhages occur from a rupture of a brain aneurysm. Fixed the aneurysm by using minimal invasive approach and placed coils inside the aneurysm. Ruth then had her standard routine 6 months follow-up. We do that on all patients that undergo endovascular treatment to make sure that the coils are not reconfigured or they have not compacted.
His nurse got back to me and told me that I was going to need treatment because there was leakage.
The uniqueness of Ruth's aneurysm is that it's located in an area where standard surgery is challenging, and explained to her the risks of the procedure. I explained to Ruth also that she would be the first patient in the United States after the Serpent Streamline. One of the flow diverters available to us was cleared by the FDA. One of the most advantage, I think, of the device is the precise placement, that it opens up all the time, it doesn't twist. Because of the high mesh density and consistent mesh density, it has a very high success rate. So these things make the device very, in my experience, very attractive over other devices.
He showed me everything as far as, the imaging, what it looked like, what they did, and explained everything. And I left there like, thank God I was here. I really didn't have any problems. And after the Stryker flow diverter was put in, you're brought up, especially when you start getting older and you hear of all these things that you're supposed to be doing for yourself, like getting exercise, eat properly and all that. Well, you all fall on the wayside no matter what. This has kind of woke me up. I'm starting to do the things I should have been doing a lot more of, but now with a different attitude, because now I'm not doing these things because I should, it's because I can. Stop and smell the roses, appreciate the day. Be in the moment, do what you're doing and enjoy it. If it wasn't for them, where would I be? How would I be? Maybe I'd still be here, but maybe I wouldn't be in this condition. I would say a great big thank you, and they know that I mean it.
Good morning, everybody. I enjoyed very much, particularly Eric's presentation. He's always thoughtful about the big picture. He also reminded me of a quote. I woke up early this morning wanting to change the world. I changed my mind and went back to sleep. So, some of the, of course, you need to have the motivation to do the things that allow people to be innovators and but those are excellent words of advice, particularly for our young, aspiring, passionate residents listening in today. So I'm going to talk about something extremely focused as opposed to very general. So I'd like to share with you my experience with what I'm calling 1D, 2R bypass for moya-moya and steno-occlusive disease. And I'll explain in a second what that is. Disclosures, I'm consultant for Lycas and Stryker and stock owner in Cogent. None of that is relevant. So Very briefly, what would be a talk from me without a little math and physics and computational flow dynamics of bypass, some surgical principles and techniques, then I'm gonna show you the technique and results of the series. Some math and physics, we're gonna be thanking Pythagoras in a second, as I'll show you how to construct bypass. You still need to remember that theorem in making your fish mouthing of the bypass. You have to think of the Bernoulli equation, although it is less useful in the context I'm talking about. And in flow dynamics, all that it says, it's essentially a conservation of energy between pressure energy, kinetic energy, and potential energy. It does not change as the fluid goes down a tube or a network of tubes. These energy forms interchange, but their sum remains the same. What is very useful and what needs to be understood very well for bypass surgery is the Hagen-Poiseuille law, which we'll come back to it a couple of times, that relates a pressure gradient, volumetric flow rate, and the vascular resistance. We'll come back to that. And those of you who still remember high school physics, really Ohm's law, electric law of is very equivalent to Poiseuille's law. You just switch R for electric resistance and flow for current and voltage for delta P, and it's the exact same formula. It's a simplistic way to think about it. I have absolutely no time to go into delve into the details of computational flow dynamics. I'm just going to give you the summary of many studies done, mostly in the cardiac coronary literature. That's where most of brain bypass science has gotten its knowledge base, from the coronary and peripheral vascular bypass. So when you perform a brain bypass, many things to consider, but particularly the geometry, the donor to the recipient diameter ratio, among other things. And why do some bypasses fail? It's either surgical injury, a compliance mismatch between the donor and the recipient. For example, if your donor is too large, you will create low wall shear stress and intimal thickening. And if your donor is too small, you will create high wall shear stress and endothelial injury. So both extremes are bad. The take-home message of many studies that I'm not showing you here is that you need to try to do the bypass at a small angle as opposed to a wide angle, because that creates less turbulence, less stagnation, more physiologic wall shear stress. You want to try to achieve laminar flow. There is less laminar flow at what is called the floor of a bypass, meaning the opposite end of where the anastomosis is done. There are stagnation points that you must avoid, and some other probably more detailed things you may not be too interested in. Low wall shear stress means less than 5 dyne per centimeter square. As I said, causes intimal hyperplasia. High wall shear stress is also bad. It causes endothelial injury. Fascinatingly, at least in humans and mammals, vessels will adapt to achieve a certain wall shear stress, whatever you do to them. And that is around 15 dyne per centimeter square. And as I said, a lower angle. So this seems, when you talk about a biologic constant for vascular surgery, this is probably it. Vessels, when you do a bypass, they will adjust over time, as you can see in this graph, not to adjust their diameter, not to adjust the flow. All they seem to care about is achieve a certain wall shear stress. And that explains a lot of vascular modeling that occurs. Technical tips: you need to have as short length of a bypass as possible. If you think of the Poiseuille's law, L is vascular resistance is proportional to L. The donor over recipient ratio needs to be ideally in the range 1.5 to 2. If there is great discrepancy, you will have problems with the bypass. Fish mouth the donor, you'll see why in a second that's useful. Try to achieve a 30 to 45 degree angle. Of course, ideally, you want your donor to be parallel to the recipient, but if you think about it, that means it's an infinitely long anastomosis. That doesn't work. So you need to compromise. And place more sutures at the toe and the heel of a bypass. Surgical principles, there are 3 ways to do a bypass. This is from a previous chapter we've written. This is an end-to-side bypass. The one that is best is the one on your right, because it increases by 4 times the cross-sectional area. When you do an end-to-end bypass, that's why you also slant the donor and the recipient to avoid stenosis. And lastly, the side-to-side bypass, like this, you are obligated to know how to do a running suture for the back wall. You cannot get away with an interrupted suture because it's an inverted bypass in a way. So technically you need to master this running suture. And this is how my preference is when I do a side-to-side. I place the arteriotomies at what I call 130 and 1030, not 12 and 12 or 3 and 9, because that's the best compromise. So now I'm going to bring you to our recent series that is being submitted to JNS. Well, I'm calling it 1D2R, but before I tell you anything about it, extreme thanks go to Nick Khan, my current spectacular fellow who spearheaded this project, and many, many thanks to Victor Liu, Turkey, Michael Silva, Arya, and Ian, who contribute to the project by looking up the data, and also Ian by sharing his engineering thoughts about parts of the paper. And also many thanks to Roberto Suazo, our spectacular medical illustrator, who is absolutely priceless, of course. So what is this about? Well, you know, ECIC bypass is commonly used for moyamoya disease, moyamoya syndrome, and atherosclerotic occlusive disease. It is a flow augmentation procedure in this setting. It's not a flow replacement procedure. Flow replacement is when you do aneurysm trapping. I'm talking about flow augmentation. And there are many different ways. You can do one donor to one recipient. I'm calling this 1D1R. You can do one donor to 2 recipients, which is what I'm discussing. You can do one donor, 2 recipients, which is what I'm discussing today. Or you can do 2 donors, 2 recipient, 2D2R. I'm going to show you later the advantages of why I'm doing a 1D2R in select cases. Number 1, before you do a bypass, you need to figure out, does the patient need the bypass? Of course, these are the usual sources of natural collaterals in moya or cerebral ischemia. You can have natural collaterals, transdural, you can have retrograde from the posterior circulation, or you can have via the ACOM. I am a big fan, of course, of quantitative flow measurements, and I've been using them for more than 20 years now on essentially most vascular cases, be it aneurysm clipping or particularly bypass surgery. This is how it's done. For example, this is at the completion of a 1D2R bypass, measuring the flow of 63 cc per minute. And I've, of course, recorded all these numbers on all my cases. This is a 1D2R, one branch of the STA, anastomosed side to side to a frontal branch and end to side to a temporal branch. And you can see how I've measured the bypass at both sites and again recorded all these numbers before the bypass and so forth. This is generally how it's done. A craniotomy centered 6 centimeters above the external ear canal, looking for one branch, usually the parietal branch, and leaving the anterior branch of the STA undisturbed. And you'll see the advantage in a second. So perhaps the best thing, let me know, Iggy, if the video
We are presenting a surgical case of bypass surgery for
Yes,
moyamoya
sir.
See the
syndrome.
video, Ignacio?
Yes,
Okay,
doctor,
thank
I
you.
can hear it and everything is good. You can start from the beginning.
Old man presenting with right-sided body hemiparesis with several attacks and limb-shaking TIAs. He was obese, African-American, without sickle cell disease, with slight right upper extremity weakness when examined. There was also cognitive decline. An MRI revealed ischemic regions in the left MCA territory, as seen on this MRI 10 days prior to surgery.
So I'm going to speed a little bit through this. You can see the severe hypoperfusion, delayed mean transit time. You can see it there in the middle, low CBF. And even after his angiogram, he actually worsened. And this is an extension of his ischemia. So and you can see his angiogram. This is area of uncompensated hypoperfusion.
Changes on the left side with area of uncompensated hypoperfusion. The left superficial temporal artery has two branches, the anterior and the posterior branches.
So we're going to do a bypass, urgent bypass, because of his saccadic changes. And I'm going to skip through all that, just perhaps to show you some technical aspects. Here is the incision at the back.
The galea from the underlying STA. Often it is easy to mistake the superficial temporal vein for the artery. Here is the artery harvested. It is filled.
We put heparins in it. We use a Colorado needle. We then do a small 4 centimeter craniotomy centered on the Sylvian fissure. We identify two recipients, one on the frontal side and one on the temporal side. I like to put glove as background. We're measuring the diameter. And now, here is the sequence of events.
Diameter. I measure the recipient flow, and it was 3 cc per minute antigrade in the temporal M4 and 10 cc per minute antigrade in the frontal M4. The donor posterior branch of the STA is now cleaned very well from adventitia. And
so again, I'm going to speed through this. In this particular case, I did end-to-side anastomosis first, but that's atypical. When you know you're going to do a double barrel, you should do the side-to-side first to allow the flow to go through that bypass while you are doing the end-to-side. But in this case, we did it the other way, not knowing that we're going to need the double barrel. So again, this is not a lecture to show you specific techniques, but in this case, we use interrupted. Now you measure the flow.
Measure the flow after the bypass. It is important to position the donor artery in different positions to make sure it does not kink on itself. And the measurement of absolute flow will help choose the optimal position to proceed with the second anastomosis of the frontal territory. The flow in this position is now 58 cc per minute, which is higher than the cut flow obtained at the dissection of the artery.
So now I proceed with the side-to-side bypass, and you can see the same donor going to the other recipient. In this case, I did. You see this, you have to do the running suture at the back. So we're doing the running at the back, and I believe I used interrupted at the front wall. You finish your anastomosis, you remove your clips, and now you make your final measurements. Notice final measurement in this case, 63 cc per minute antigrade, which is higher than the cut flow that we started with. And this is ICG.
You can see the milking test done there.
And you've established its patent. And I'll come back to the advantages of doing this. And this is the final table of flow on this case. And I do this on every case, every bypass case, sequentially. This is post-op CTA, patent. Both bypasses are patent. Patient did very well. No more TIAs since I've done this, I believe, 10 months ago.
Weeks later.
So going back to the mechanics of this, the analogy is electric circuit in series and parallel. By doing a double bypass, you're decreasing the vascular resistance. This is the concept actually that Nick came with and suggested it to me, Nick Khan, about uncompensated area of perfusion, of hypoperfusion, how you look at the angiogram to figure out. So I'm reporting the data of the 21 hemispheres that I've done a 1D, 2R. This is out of a much larger series, which were also reported, where I've done 1D, 1R or 2D, 2Rs as well. This is a nice Suazo illustration for our paper showing the 3 steps I showed you. Step 1, step 2 is the first anastomosis. Step 3 is the final double anastomosis, and you can see where I measure flow at every step of the way. What are the results? It's the usual demographics. This is 21 hemispheres, more females than male, more blacks than whites, same as white and Hispanic, one other, mostly moya-moya disease. There was 1 case of atherosclerotic disease, 3 cases of sickle cell, 1 case of radiation vasculopathy. We measured Suzuki grading. I'll skip some of this stuff. So bypass patency, 100% immediately, but 90% patent bypasses on delayed follow-up. That 90% is due to 1 patient who occluded I did both hemispheres, both occluded bilaterally in a delayed manner because he grew very robust indirect collateral. So it wasn't a technical problem. It was that the direct bypass was not needed anymore after many months in this case. Notice again the flow measurements. This is so-called cut flow index. After you do the first bypass was on average 0.64, but doing the second bypass, the second anastomosis increased it to 0.94. So it demonstrates very well how you can increase the flow by doing a double anastomosis. By working with all these numbers, the overall donor to recipient flow increased on average by 50% with the addition of the second anastomosis. And the MRS in the 21 hemispheres, in the 19 patients, 21 hemispheres improved compared to pre-op. This is a nice view how when you measure cut flow on the left, you do the first anastomosis, you measure the flow, that's a middle column, then you add the second anastomosis, you increase the flow again. That's why that CFI, cut flow index, the ratio of total flow to cut flow increases when you do a double bypass. Here I studied whether it matters whether you do side to side or end to side first. It really doesn't matter. These are the clinical outcomes. A reminder of the really simple equations that belie some of those calculations. This is again a lovely illustration by Suazo, which we're hoping will make it on the front cover if they accept the paper. And this is an electric circuit analogy to what we are talking about in these. And I'm not going to bore you with the details of these equations and calculations. So the benefit of a second anastomosis is that the contribution of the recipient territory vascular resistance drops from 40% to 17% by adding it. In that paper, we introduced 2 novel concepts that have not been described before. I call them SARA and SASI. You always have to come up with catchy names. The SARA is a second anastomosis relative augmentation. You simply divide cut flow index final by cut flow index initial. And SASI is a second anastomosis sink index. It's a measure of how much the second anastomosis contributed to the total flow. And we've tabulated SARA and SASI for each one of our patients. This is a typical case. You can see at the right side, the final post-op, how much blood flow has been sucked in after 10 months of the bypass. The only one patient who occluded bilaterally, as I told you, occluded because the bypass was not needed. rather than a technical problem. And this is the detail of both hemispheres of this patient who occluded. You can see the bypasses were patent immediately post-op on your left side. The top is right, the bottom is left. And then you can see the bypass slowly disappear over time, and that 1 year post-op, there was good indirect transdural flow. This is a table showing why the advantages of the 1D, 2R. In essence, you decrease healing problems because you leave the anterior branch of the STA running to the scalp. You increase flow. Now, it is important, of course, to be fairly experienced, because if you screw up the bypass, you're going to screw up 2 anastomoses in one go. So I don't think it's a bypass to be done by beginners, but it's not really particularly very difficult, certainly much easier than doing high flow radial artery bypass. I am not going to discuss with you, it's all for the paper, how we shortened the L and we diminished the R in those equations with the 1D, 2R, and what our SARA and SASI numbers were on average. Conclusion, the application of this technique in a series of 21 cases demonstrated high patency rates, achieved statistically higher flows compared to 1D, 1R without sacrificing the second donor branch, and patients got better. Only 1 patient developed a hematoma and no patient developed ischemic changes after these bypasses. But I will be encouraging my colleagues who do bypasses at other institutions to try to use the SARA and SASI concept if they do these cases and report their experiences. And I think, and again, I'd like to thank very much our residents and Nick and Suazo for the help with this project. And now I think it's Eddie Vanderwerf from Stryker CMF, who will talk to us about innovation. Eddie, are you there?
I believe I'm gonna go ahead and run the video for Eddie. Okay, stand by.
Okay.
Hello everybody, my name is Eddie, and today I'll be showcasing Stryker's Adherus dural sealant. We have 2 options, extended tip and regular, comprised of PEG and PEI. PEI is actually antimicrobial by nature, probably resulting in our 0 device-related infections. The 2 of them combined create 17 crosslinks. This really builds and adds strength throughout the entire time and minimizes swelling. Our competitor only has 4 crosslinks. 90 days to resorb, our competitor 4 to 6 weeks. 60 seconds to set up, and a great OR applicator. Want you guys to try it, you're gonna love it. I've actually included 2 marketing videos for your review as well. Please let me know if you have any questions. Thank you so much for your time, and good luck with the rest of your presentations.
I believe, is Carolina Benjamin next. Carolina, are you here?
Good morning, everyone. Can everyone hear me okay?
Yes, we can hear you loud and clear, doctor.
Okay, great. My name is Carolina Benjamin. As you all know me, thank you for having me here, Dr. Levy, Dr. Morcos, and to all of our industry sponsors. Today, I'm just going to be talking about the use of virtual reality platform combined with diffuser tensor imaging and the preoperative planning and intraoperative navigation of deep-seated cavernomas. I have no relevant disclosures to this talk. So, I mean, most of the people in this symposium know, a lot about cavernous malformations, but they're common vascular anomalies consisting of cluster of capillaries without intervening brain tissue. Oftentimes, they're found in deep-seated eloquent cortex, so they can pose a significant management challenge. Surgical resection, when indicated, is going to carry a high risk of postoperative neurologic deficit, and therefore obtaining a safe surgical access is going to be dependent on the location, the patient's clinical status, and the technology available to us. So I think, to echo some of the points that Dr. Peterson mentioned earlier, we as surgeons and we as doctors think very differently than most other industries. And we very frequently are narrow-minded, like he mentioned, and we're sort of go through this formal training, protocol training, and we don't necessarily have this thought process of how can we maximize our success. So obviously, after medical school, we go through residency training, and a lot of times in specialties like cerebrovascular, skull base, you should probably do a fellowship, which allows you to get some of this experience. But there's always somebody there. So the question is, how do you maximize your success for when you're doing these complex cases after you finish residency and you're out on your own, finish your fellowship training? And I think, we can sort of learn a little bit from the industry, the pilot industry. Pilots sit there and they go through simulation training. Sure, they have formal training and they have hands-on experience, but I think oftentimes they really do have this simulation program that's a lot more intensive and more rigorous than what we do as surgeons. So I think we can sort of think of technology as our friend. And we can use that to our advantage, the way that other industries, including the pilot industry, uses. So obviously, this is not going to replace your anatomy. This is not going to replace your knowledge. So first and foremost is going to be your training and your knowledge of anatomy, not only in the textbook but also in the lab. So that's never going to be replaced. But I think what I'm talking about in this particular talk is really that technology can be used as an adjunct and it can help you. So a lot of what I have in this talk are types of technology that we had available to us in New York and that we used. So we used these three-dimensional virtual reality platforms to assist us intraoperatively as well as preoperatively. We used neuronavigation, of course, and then we also used, we relied heavily on diffuser tensor imaging to give us better understanding of each particular patient and not only their anatomy, but the relationship of their pathology with their inherent anatomy. So I'm going to look at the short series of 6 patients who underwent surgical resection for these deep-seated cavernomas in eloquent areas. And we used the 3D images. They were created from DTI imaging pre-op, and then we used a virtual reality planning software, surgical rehearsal platform. And we were able to integrate the surgical theater system with the neuronavigation system. So you could actually have real-time evaluation of the 3D tractography. So you get your imaging, you get the 3D tractography from the imaging, and then you're going to upload that not only to the surgical theater system, but you're going to have it incorporated with whatever neuronavigation system you're using, so that you're not only using it preoperatively, but intraoperatively when you navigate, you can navigate with the tractography in place. So it was used to assess the location of the cavernoma and the relevant anatomy. You could map out multiple trajectories and compare the advantages and disadvantages of each. So I think the benefit of this is that many times if you have a complex case, the next day you're sort of going to, the night before, you find yourself thinking of the case and you want to sort of plan out exactly what you're going to see when you get there, what cortical veins are you going to encounter? What's going to be the difficult part of the case? And you sit there the night before and you're planning all these things. What this approach allows you to do is to do that planning ahead of time. You can do that planning in the office. You can do that planning, with other partners around, and you can do that planning to help your chiefs or your residents who are working with you sort of prepare for the case as well. One thing that I was always amazed by my mentors is, when all this technology is not available, people were able to do this. You're able to take an MRI image and sort of create a 3D picture of what this patient's anatomy is going to look like, so that my boss, my chairman and my mentors when I was doing fellowship were able to, there was no surprises. They knew exactly what they were going to encounter. And this is, you do develop this as you go through your training, but it takes time, and it's not necessarily everybody that has such an easy time doing this. So I think what this surgical rehearsal platform allows us to do is really to go through that exercise that you eventually are going to master, but it allows you to get there a little bit faster and allows you to translate what you're going to see on the 2D imaging to the 3D anatomy, and that allows you to prevent any surprises intraoperatively. And none of us like surprises when we're operating, so it really prepares us for the next step. Just a little bit about the DTI technique. This is not, I'm not going to go into the details of the physics of this, but essentially it's just a diffusion weighted image. So oftentimes when I'm working at Jackson, the residents will say, oh no, there's no DTI at Jackson. There is. You are capable of doing this. The only difference is that very frequently when the DTI is done, what you need is a tech or a radiologist who can post-process these images so that it actually creates, the 3D tractography that we're used to. But it is something that's very manageable to do. You don't need, any sort of crazy magnet or 7T or anything like that. You're able to do this with your regular diffusion weighted imaging. It's just about the post-processing. And then for some of the residents, just so you get these pictures and oftentimes they're like, oh, the DTI is not helpful. No, it is helpful. So in blue, what you're going to end up, your blue fibers are going to be anything superior to inferior, so your like cortical spinal tracts. Typically red is going to be left to right, so callosum, anything crossing midline, and then green is going to be your anterior to posterior, so like RQ at optic radiations. And very frequently these aren't necessarily color coded unless you can specify to them that that would be helpful to you. But again, it is available to you, and you can ask them to label it so that that's going to be a useful adjunct for your preoperative planning. Then in terms of the virtual reality platform, there are multiple platforms. Like I mentioned, we specifically use surgical theater, but it allows you to convert that two-dimensional black and white DICOM image to the three-dimensional colorful virtual reality objects. So this can be projected onto the patients in real time. Your images do have to be 1 millimeter in thickness to allow for accuracy. But it not only allows you to actually paint the patient's pathology. So if it's a tumor or a cavernoma or whatever it might be, you can paint that on based off of your MRI imaging. But it also allows you to create openings, bony openings, corridors through the brain parenchyma. And it also allows you to import 3D tools and objects into this virtual reality scene. So for example, a lot of these deep-seated cavernomas that you use the assistance of a tube, you can actually import the tube into your scene so that you're thinking, okay, well, this is the tube going to fit? Okay, there are two superficial cortical veins. What's the best corridor that I have in order to get to where I can get to most in the safest manner? And you can also view this in a flat touch screen, or also you can have these virtual reality headsets, of which there are many that you're able to use. And this actually in particular, you can have one of these flat screens with you, and I think I have pictures of it here. You can have it in your office. So, this is something that's not only becoming useful for resident training, but also patients are really, you can have this with your patient and sort of go over exactly what you're planning to do. Having come from somewhere like New York, I can tell you that that was something that was very, as a marketing technique, number one. Number two, it sort of really allowed patients to understand the complexity of how deep the pathology was and how complex it was. And it really sort of puts into perspective what you're actually doing in the operating room. So it can be an education technique. It can be used in the clinic. And you can see here on the bottom right, it can be used intraoperatively. and integrated with your neuronavigation system. So the locations of the cavernomas that we particularly we did in these cases were the left caudate, right superior colliculus, right posterior inferior thalamus, right insula, left medulla, and left pontomedullary junction. Most of these patients underwent microsurgical resection. One patient actually underwent endonasal resection. That was interesting, and I'll show a little video of that because that patient, we were in looking at the fiber tracks, we sort of saw that the endonasal technique really gave us the most direct access. And sometimes you think that and you can study your anatomy, but this sort of just makes it so clear for you that you know exactly what you're getting into. All patients did relatively well. 2 of them who presented with a deficit required rehab, but did improve neurologically. 3 patients remained neurologically intact, and 1 patient presented with a nerve palsy that remained stable. And gross total resection of all the cavernomas was obtained. So just as a case example here, you have a 59-year-old. He presented with a progressive left hemisensory loss and dysesthetic pain syndrome, 16-year history of this cavernoma, and had multiple symptomatic bleeds. So with expansion of the lesion and these bleeds, he presented to us and we discussed surgical intervention with him. So you can see here sort of the planning process. Here's the lesion up top on your post-contrast MRI, axial images. And then what you do is you use those DICOM images to create this three-dimensional image, which you can incorporate into your surgical theater or whatever virtual reality platform. And then you create your different approaches, right? You can create your trajectories. So for this particular patients, we looked at 3 trajectories. We looked at the parieto-occipital transventricular approach through the superior parietal lobule. We looked at the posterior interhemispheric transcallosal approach. And we looked at the superior cerebellar infratentorial approach. And ultimately, we went with the superior parietal lobule approach, parietal occipital transventricular, because that really sort of maximized our corridor. And you can see here, one of the really nice things about this is you can look at what you're going to see on your surface projection. You can look at the veins. And oftentimes, working in between the veins in this area here, it can be very tricky. And a venous infarct in this area can be devastating. So it really allows you to plan your best window that you have. And then again, here's the use of incorporating a 3D tool that you can actually insert into the scene. And then do sort of a little bit of, okay, what are we going to see when we actually get there? And obviously, intraoperatively, you're not going to be seeing the fibers. You can try to project the fibers onto your neuronavigation, and that can be helpful. But it's nice for you to, in your mind, think of what are my danger zones. That's something that we typically do as surgeons, as where in this procedure can I hurt the patient? So this really makes it clear in your head as a 3D image, so that when you get there, you have that in your mind, and you pay closer attention when you're working on those trickier spots. So this was the final approach that we took, the superior parietal lobule. It gave us this nice window here. And it also maximized the distance between the optic radiations and the somatosensory cortex. So I think I have a short video here. A lot of people are concerned about whether or not, I'm going to just play ahead. This was the image, the different trajectories that we looked at. And then you can actually create these nice videos that allow you to sort of like a fly-through video of exactly what you're going to be looking at. But yeah, a lot of people are concerned about, okay, this is too much. This is too many things to bring into the operating room. This is going to slow you down. Well, not really. You can see here going through the tube, which is really nice. It doesn't really slow you down, it's just like similar to the neuronavigation. It just sort of sits on the side here. You can see the setup. So it's not like it's bringing a lot of bulk into your operating room, and it really allows you to create a nice trajectory. And this is, you can see here, this is incorporating it with the brain lab trajectory. This is performing the sulcal dissection before inserting the tube. And you would do this in the same way, but you can see there's actually an outline as well of our pathology that we did with the brain lab and the heads-up display on the brain lab. So there you go, inserting your tube, and again, your heads-up display remains there, showing that you're going in the right trajectory. This is working at the depth, and you're going to get through the ventricle here shortly in order to get to the thalamus. There you are. Now you're in the ventricle, and we can advance. There you go. So, okay, now we're in the ventricle, and we can see exactly where our lesion is. It tells us that we're in the right spot, and allows us to really know exactly where we can enter the thalamus so that we can do this in the safest manner for the patient. Okay, just gonna play ahead here. And, this is just, once you get there, this is really a planning thing, and your approach, once you get there, the resection is sort of the same. So I'll play that ahead and just show you the post-operative imaging for that. So the patient did very well, no residual cavernoma. Okay. So another example, and this is our endoscopic example, which I thought was quite a nice little approach to this. Is 51-year-old with acute double vision, dysphagia and balance difficulty. She had a complex medical history, so initially was treated conservatively, but after multiple hemorrhages, surgical resection was offered. And on exam, she had a cranial nerve 6 palsy. So again, here's the lesion on our just usual MRI imaging here on the left, and then on the right, you can see where the cortical spinal tracts were pushed. So essentially, our endonasal approach gave us a very direct approach to this. Let me see if I can actually show you the surgical video, because here, bring this up a bit, because and I'd like to show you the beginning, just in terms of the planning. Here we go.
But due to a repeat hemorrhage.
So this is just the example of using the surgical theater and how you can shave away. You can shave away bone, you can shave away different things. So you know exactly what you're going to get into step by step.
Tractography revealed that the cortical spinal tract was medial to the lesion. The lesion appears to come to the PL surface and be accessible through the transclavial endonasal approach medial to the carotid. We therefore chose the endonasal transclavial approach over the far lateral.
So once you, again, the nice thing about the planning is really that it shows you how to get there. And once you get there, the resection is really going to be the same. And I won't go through this video at length, but let's go back to the presentation here. All right, so you can see, again, here's the cavernoma coming up to the surface. The abducens nerve is here, medial pons. The basilar is actually not seen in this picture, but this really explains why she had the abducens nerve palsy. But the tractography and the surgical theater really showed us how, if we were to take this approach, we're going to be safe, and it's going to be very easily accessible. So you can see here the result after having resected the cavernoma and the post-operative imaging. So conclusions, I think virtual segmentation really allows for better understanding of the complex anatomic relationships between the lesion and the surrounding critical structures. And it also allows you to tailor the approach, not only to the patient's pathology, but also, how the pathology is impacting the patient's normal anatomy, whether, things are shifted, and it really allows you to prepare yourself for those things such that there's no surprises when you get there. Advanced planning familiarizes the surgeon to the patient in the context of the surgical field, and it also increases spatial and positional orientation. And 3D virtual reality planning platforms in conjunction with neuronavigation and DTI can assist in choosing the optimal surgical corridor to achieve a gross total resection of not only deep-seated cavernomas, but also other pathology. You can use this. This is very frequently used in some complex skull-based approaches to know how much bone to take and how to get to your lesion most safely while minimizing neurologic deficit. Thank you. And I believe it's Integra that's going to go next, Dr. Marcos.
Good morning. My name is Jeff Rivet, and I'm the account manager for Integra Codman Specialty Surgical. Thank you for your time. Integra is honored to sponsor and support the University of Miami Neurosurgery Department and Jackson Health System. A little history about our current name. In 2017, Integra Life Science acquired Codman Neurosurgery from Johnson & Johnson, and Integra's neuro division became Integra Codman Specialty Surgical. I represent those products. The good news is that we are all one team. Not only do you have access to Integra corporate, but our South Florida team, which consists of 4 specialists. Our capital specialist, Joe Pavliga, our hydro specialist, John Ivory, our clinical specialist, Mallory Marney, our instrument specialist, Eric Simelton. Of course, I'm the account manager, and then our regional business manager is Bart Kyle. Integra has the largest and most comprehensive portfolio of neurosurgical products. From planning to the ICU, we have you covered every step of the way. Between UM and Jackson, all the highlighted products are currently in use. A few that I would like to review in more detail include the Certus Plus programmable valve, DuraSeal and DuraSeal Exact, CerebroFlow ventricular catheter, Lycox brain tissue oxygen monitor. A few key features of the Certus Plus include 7 settings plus a virtual off, MRI resistant to 3 Tesla, small and right angle valves are now available, it's position independent, it's resistant to household magnets. Outside the point of care, magnets are everywhere. Valves are subject to unintended setting changes due to strength, proximity, and hidden nature of everyday magnets. This slide shows the results of a benchtop study by the Jacobs Institute, which demonstrates that Codman Certus Plus programmable valves resisted interference from common household magnets at close proximity better than Strata 2 programmable valves. The next product I'd like to discuss is DuraSeal. It's used in neurosurgery as an adjunct to suture dural repair to achieve watertight closure. There are 2 formulations, DuraSeal Cranial, which lasts in the body 4 to 8 weeks, and DuraSeal Exact, lasts in the body 9 to 12 weeks and is engineered for the tight confines and higher pressures of the spine and is the only spinal dural sealant available in the US. So much and so that Integra makes the following value-based guarantee. We're the only company to do so. If a surgeon pre-certified in proper DuraSeal application uses DuraSeal according to the manufacturer's instructions for use, and the patient experiences a CSF leak that requires corrective surgery within 30 days, Integra will pay $5,000 to the institution to help cover the cost of the second surgery. I also wanted to point out that you currently have multiple ventricular catheters available for your patient population. The CerebroFlow catheter is indicated for interventricular hemorrhage patients at risk for catheter occlusion, and our Bactiseal antimicrobial ventricular catheter is utilized for infection prevention. Finally, we are currently providing training on the Lycox brain tissue oxygen monitoring system in the neuro ICU at Jackson, where we are today. Please contact me with any questions or if you would like additional information on any of Integra's neuro products. Again, thank you for your time and we appreciate your support.
Thanks, Jeff, very much. And last but not least, Mike Ivan.
Okay, great. Thanks so much for everybody who's sticking around to the end. My name is Mike Ivan. I'm one of the neurosurgeons here at the University of Miami, specializing in brain tumor, skull base, and epilepsy. And today I'm going to be talking about technology that we use for glioma surgery and really focusing on kind of the lesser known of the gliomas, which is the IDH1 mutant glioma. And what technology we kind of use throughout our practice to kind of improve that and what we're developing. Here's my disclosures. So we know as surgeons and clinicians that all gliomas are not the same. We've had classifications of them for many years, and primarily they've been pathology based, which is talking about grade 2, 3, and 4 gliomas. But what was clearly identified for the last 30 years is that within those classifications, there are significant differences. And really one of the most important ones was identified in the early 2000s and then kind of discussed here in this New England Journal paper in 2009. And that's what was the IDH1 mutation, which is a mutation that happens in these gliomas in about 10% of them. I'm not going to go into the chemical kind of makeup of them for lieu of time, but they're in younger populations, as we could see here from this cohort. They're much more common in 44-year-olds and less. and they also are much more common to have a TP53 mutation or ATRX mutation. And you could see the most important characteristic is that in glioblastomas or in grade 2 or 3 gliomas, when you have an IDH1 mutated tumor, the survival benefit is almost double in a glioblastoma case, and in a lower grade, grade 2 or 3, it's sometimes even triple. And so identifying this mutation and knowing how to treat it is much different than with wild type tumors. It's different, obviously, probability of recurrence, survival, and treatment paradigm. And the understanding of the difference between these tumors and why they could both be gliomas, but one have this mutation have such a different survival and proliferation is because this mutation happens very, very early on. There was this controversial paper that came out talking about glioma precursor cells early in the 2000s, and this ability that this kind of stem cell or precursor cell is the initiation cell for all gliomas, low grades and high grades, but yet the mutations that occur along them may alter how this tumor grows. And if it's an early mutation, it could go and skip the grade 2 and 3 and go right to a primary glioma versus going through this kind of transition of grade 2, 3, and then 4. And that was made kind of confirmed as we've learned more about the molecular pathways, and then finally as we kind of understood this kind of integrative genomic analysis. And as we're learning more about this, we could kind of see that not only is it just matter if you're grade 2 or grade 3, but the mutational status of IDH1 as well as TERT is really important with understanding survival. And that's independent of surgery, independent of treatment. And so these two papers that came out to New England Journal over the last 5 years have kind of proved this point. And what was interesting in this one most recently was that a low-grade glioma that's wild type actually lives worse or less, has less survival than an IDH mutated glioblastoma. So a grade 4 tumor with a mutation actually has better survival chances on a 5-year curve than a low grade with wild type. And so this mutational status is becoming much more important, and as such, the WHO classification has now for the first time kind of included these mutational status in subtypes of gliomas as equal importance as understanding the other pathological characteristics such as necrosis and hypervascularity. So how do we tackle these tumors in our team and our brain tumor team? And it first becomes on diagnosis, which where we have specialized pre-tailored imaging, we have focused surgeries, we understand the mutation more thoroughly, and then we have patient-directed medical therapies. And looking at the imaging in and of itself, IDH1 tumors, mutated tumors, are often imaged differently than wild types. And the thought process in the past, or at least when I was taught as a resident, was that many of the wild type tumors tend to be non-enhancing when they're low grade. And when it is non-enhancing, it's typically a low-grade tumor. And so we looked at that in our cohort of patients, and we actually found that in over 100 patients that almost 30% of the non-enhancing lesions ended up being high-grade. Obviously, there's a big difference if you include age, and the lower age people are much more likely to be low grades than high grades, which is what we know already. But when you look at kind of how the breakdown occurred in the non-enhancing gliomas, only about 30% of them ended up being a mutated tumor, whereas 82 out of 111 were wild type. And like I said before, only 30% of them ended up being, and 30% of the non-enhancing tumors ended up being high grade. So the imaging characteristics just by the enhancement is not very accurate. So what else do we have to kind of help predict this information before surgery? There are tumor characteristics such as one paper here that was talked about the T2 flare mismatch is very highly sensitive for IDH1 mutant gliomas. And the thought process here is that faster growing, more aggressive tumors tend to induce more cytotoxic edema, induce more T2 flare around the tumor, and those tumors tend to end up being the IDH wild types. And this picture actually had a pretty good correlation. It was like 79% correlating with the T2 flare mismatch with these tumors. Location is also interestingly correlated, and for some reason, the frontal lobe and insular tumors tend to have a higher rate of IDH1 mutated tumors than other ones. There's also been some studies now that can actually look at kind of the TERT mutation that they're developing at UCSF. MRI perfusion to understand whether or not this tumor is actively growing or whether or not its treatment effects. We've looked at here at the University of Miami, looking at kind of 19 samples where we look at kind of pre and post-operative perfusion with intraoperative understanding, and we could say that MR perfusion actually is very, very helpful in glioma surgery and glioma tumors in predicting recurrence versus radiation necrosis or just treatment effect. But with metastasis, it's actually much less correlative than we would like. Macarena de la Fuente, who's one of our neuro-oncologists, is working with our radiology team here to kind of look at MR spectroscopy. One of the downstream chemicals that's made is called 2-HG, and we could actually pick that up on an MR spectroscopy here as a peak, a later peak. This is your typical NAA choline peak that's more on the left, and 2-HG kind of falls in between them here. And by imaging these tumors, you could actually have some inclination of whether or not there's 2-HG being produced and whether or not this is an IDH1 mutant tumor from the get-go. So far, this data has only shown about 60% accuracy, but it's still early, and I know they're kind of working on improving the algorithm and machine learning on this a little bit to see if we could get that percentage to be higher. So once we get to tumor surgery for low grades and for IDH1 mutants, because they have a longer lifespan, the importance of extended resection and preservation is even heightened, is more heightened. And so as a brain tumor surgeon, we're always trying to remove as much as we possibly can, always by being safe and preserving the function. And gliomas, this is really put to challenge because in many cases, there's an overlap of in kind of an integration of functionality and tumor at the boundaries. But it's no question that we know that this is a fact that the more tumor we remove, the better people do. This has been proved over and over again for the last 25 years. But what is the situation specifically for IDH1 mutants? Is this kind of idea of the more you remove, the better it is, even for slower growing tumors or tumors that are less invasive, like an IDH1 mutant tumor. And in fact, in 2005, 8, and 13, there was 3 different studies showing low-grade gliomas have the extended resection. It does improve outcomes. And also with subtype, with the actual subtype classification of IDH1 mutated, they do. And the other thing is that for low-grade gliomas, the more extended resection that you do prevents the transformation from this becoming a higher grade tumor. And that was shown very nicely in this 2012 paper in the Journal of Neurosurgery, that there's a 10-fold reduction in transformation by performing a greater than 90 to 100% resection of low-grade gliomas. So what tools do we have to try to achieve this in our surgery? We're at the University of Miami for the last year and a half. We have 5-LA that we're able to use. This is a drug that's given to glioma patients preoperatively. Here's what the tumor resection looks like under white light. To a very experienced surgeon who has done hundreds and thousands of these, that you can tell the definition of the tumor from the normal brain by the consistency, how it reacts to coagulation and sonication, and the small microvascular changes that occur. But to junior faculty, it remains quite difficult to kind of make that delineation. And 5-LA really does help with identify what residual tumor is. And in this case, you could see here that there was residual tumor, indicating that if it was safe, if it's safe to continue, if there's no functionality, whereas if you use Carolina's, onlays of the tractography and kind of inlay in that, and you know that this is a safe place, or if you use mapping, you could continue the resection. Here's just a short video of kind of what it looks like during one of the cases here. And you can see the bright pinkness is quite obvious as you're kind of removing the tumor itself. Thanks to Dr. Stumer in Germany, we now have a phase 3 clinical trial that shows that 5-LA actually does increase progression-free survival as well as extended resection. There was early data to show that this does increase survival in these patients. However, 5-ALA doesn't work in all cases, especially in low-grade tumors, which is most cases where IDH1 mutated tumors are. So grade 2s and grade 3s, it's not a sure bet that you're going to find fluorescence. And so this was an interesting paper that came out a few years ago in Aqua Target talking about specifically IDH1 mutant and 5-ALA. And they actually identified that if the low-grade tumor is IDH1 mutant, there's actually a threefold chance that it would end up being 5-ALA fluorescence with that low-grade tumor. So 75% of the mutated IDH1 low grades ended up having fluorescence, were only less than or around 20 to 30% of the patients that were wild type that were low grades ended up having fluorescence. So they suggested in their paper that 5-ALA fluorescence positivity in a low grade resection could actually be partially diagnostic. Now, obviously, it's not a 100% accurate, but it does help. And the reasoning behind that is within the pathway of IDH1 mutation, and without kind of belaboring the point, because of the pathway of the creation of the alkyl glutarate and the 2-HG, you decrease the amount of NADPH, which is important for regulating the ALA synthetase and kind of degrading the 5-ALA quickly. And so because you're not able to do that, more 5-ALA builds up in these cells and you end up having higher fluorescence. So without being able to know if all the 5-ALA fluorescence is tumor or not tumor, what are the other options we have for resection other than using your navigation? And that's something called supramaximal resection, which is saying these tumors are in a very non-eloquent area and you can resect well beyond the enhancing border to try to get all of the tumor. We've looked at that here at the University of Miami in a retrospective kind of matched cohort where we looked at just tumors in the right frontal lobe and right temporal lobe, and whether or not we able to just remove the lesion itself, or if we remove the lesion and a significant boundary around it. And not surprisingly, we found that there was an improvement in these patients, a significant improvement in overall progression-free survival, as well as overall survival. But what is the cost to the neuropsychological outcomes in these cohorts? And that really has yet to be determined. And I think in every patient, it's different depending on the specific location of the tumor and what boundaries it has. And it's very, very challenging to understand. Obviously, there's some risk here with trying to do a supramaximal resection. So wouldn't it be nice if there's something between 5-ALA and a supramaximal resection where we could kind of identify exactly what the tumor is and during the resection to know that you've gotten it all out during surgery to give this patient the best possible chance. And that's something we've also been working on here, which is called Raman scattering microscopy or Raman spectroscopy with the NEO system. This has been developed by Dr. Oringer, Dr. Holland up at the University of Michigan over the many years in the Invenio team. And basically what it does is instead of taking a frozen sample section, which requires about 23 steps to process in the OR, takes about 40 minutes to get your sample back. This simplifies it by basically getting a squish prep of the specimen, going into the machine, and within 120 seconds, you get your image, which could then be directly projected into the operating room, and you'll know immediately if that sample is tumor or not tumor. And it allows you to then kind of march forward through the surgery if it's safe and continue your resection. So how good is this technology? Well, here's just a couple example slides of how you would look at normal brain, low-grade glioma, and then high-grade glioma. You could obviously see the increased cellularity and the layering of the cells as you go through it. And here's just one example of a case that we did where you can see the necrotic center here, the ring enhancing edge on the side, as well as kind of the outer flare signal. And so very easy to see the transition from kind of normal brain into very, very high cellularity tumor. So we did a small validation study here at the University of Miami just to understand if our pathologist found that this was helpful and if it decreased the time of us getting these answers in the surgery itself. With 82 patients, we were blinded, the pathologist was blinded to all the patient characteristics, and we kind of looked at the data set separately. The frozen was used by one pathologist and the SRH by another one. And we were able to find that both the pathologist looking at the frozen and SRH, the pathologist looking at SRH, were very, very similar in their ability to detect tumor or no tumor, which is about 93 to 95%, with a specificity of 100%, sensitivity 97%. And what was interesting is when we look here on the right of where the inaccuracies were, is that they were actually inaccurate in very different specimens. And with the idea that if a pathologist wanted to use both of these technologies together, they could actually synergize and actually perhaps come up with a better outcome by working together. When we look at the time saved, the setup was not optimized as far as the Wi-Fi and the internet and everything, and so we still required it to kind of call a pathologist and him to call us back. But on average, it was 8 minutes to kind of get the final answer in the OR to the surgeon using Raman, and it was almost 40 minutes on mean average time with the typical frozen sample. And I would argue that this could be shortened down significantly to less than 2 minutes if we were optimizing the system. And overall, the pathologist to actually tell you what type of tumor it was exactly the same, whether they used the frozen sample or SRH, which was about 92% accurate. So what if we took that to the next step and then applied machine learning to this pathology system? This pathology system provides digitized images, which could then be fed into a system. And then you could apply deep neural network learning, which is a way to kind of recognize patterns within each slide. And if you do this millions of times, the system will generate its own algorithm to then tell you tumor, no tumor, or what kind of pathology. So we worked with the team at Michigan, NYU, and Columbia to look at 268 patient samples with the top 10 diagnosis. We used a learning set of images of 2.5 million images for the system to learn and create its algorithm. And then we fed it these 268 patients in real time to understand if the computer could make the diagnosis of one of these top 10 diagnoses. And what we found was that the computer system with AI was 95% accurate for picking the diagnosis, and the pathologist was 94% accurate. And this is, keep in mind, this is without feeding any information. So the learning algorithm did not know the age, the size of the lesion, the location of the lesion, extra, some of the things that we would include with the pathologist at the time of the frozen. So very, very exciting. The ability for this to detect the margin now, for getting back to the point of extended resection, is so key, is the next step of focus. And preliminarily in our paper that we published, we could actually see that in these slides where you could see a full slide of tumor, a slide of half tumor, half normal brain, and then a slide of just normal brain. Can it delineate the probability of tumor, not only within the total slide, but within portions of the slide to kind of identify, are you at the boundary or are you not at the boundary? And it can do that, but the question is what is the sensitivity there, and how do you interpret that? Is it just, if it's 1 or 2 cells, is that too sensitive? Or if it's 10 cells, what is the minimum that it could pick up to kind of identify any tumor on a slide to let you know that that margin is definitely clean or not clean? And those are kind of the limitations that we're trying to understand at this time point. So what did the future hold for glioma surgery? I think that if you combine the complex radiology that we are able to do and use AI, which many people are doing now, and machine learning, you could kind of begin to predict where the tumor is and where perhaps the hot spot within a tumor may be. We have already abilities to do stereotactic and robotic surgery with our navigation systems in order to do that. And we have the ability to kind of detect what the tumor is. You can imagine somebody coming in, instead of just to get an MRI scan, to come in to get an MRI, biopsy, and pathology all within the same kind of machine, and get their kind of diagnosis within an hour, and then go home. And I think we have that ability with machine learning and AI and the technology we have by combining it to kind of have that possibility in the very, very near future. Obviously, there's a large team here that I work with at the University of Miami, and I'd like to thank them all for their support with all of the research that we do. And thank you for letting me talk to you guys today. That's the end. Thank you. Okay, I think after me, we have 2 more speakers. We have Osteomed and then Medtronic.
Hello, and thank you for the opportunity to talk to you a little bit about Osteomed, CMF, and neurosurgical. We were established in 1991 and privately held by Coulson up until recently, when we were purchased by a Berkshire Hathaway company, Marmon's Holding. We still remain headquartered in Dallas, Texas, and manufacture everything here in the United States of America. In 2018, we brought on a new sales leadership team led by former Stryker CMF Director of Sales, Seth Brousseau. Since that time, we have invested heavily in new partnerships and advanced neurotechnology, as you'll see in the coming slides. Recently, we merged with Acumed, another part of the Coulson Medical Group, making us one of the largest orthopedic and CMF companies in the world. Locally, your rep is Danny Valeris. He's been with OsteoMed for 2 years. You can see his cell phone and email address listed here. And the products you're probably most familiar with in the community is the Profile Zero low-profile neuroplating system and our Profile Plus standard neuroplating system. The Profile Zero is the lowest profile plate and screw construct on the market in the US at 0.25 millimeters thick. As you can see by the images, the plate and screw create a flush interface, which helps with patients that may have thin skin or when just plating on the frontal bone. Our Profile Plus is our standard plating system at 0.5 millimeters thick. As you can see, the plate screw construct is not as flush as the Profile Zero, and the added material on the head of the screw allows for slightly greater screw retention. Our Pinnacle driver is the best-in-class intelligent smart driver, which places screws at a speed of 2,000 RPM in less than a second. The cool thing about the Pinnacle is that it has a torque limiter, so you don't have to worry about stripping out the screw hole. The technology built in will stop the screw immediately when it is seated. A more standard driver is our Osteo 2 disposable driver. This does not have that torque limitation. However, the speed does not go up to the 2,000 RPM that the Pinnacle does, so you have more than enough time to anticipate when the screw's seated properly. Of course, if you need mesh, we have everything from dynamic mesh, flat, pre-contoured, that you may need for reconstructing after a large defect is removed. And if you need something in the patient-specific implant space, we have all three main materials that you see on the market. We have the polymethyl methacrylate, PMMA, which is called ClearFit, a porous polyethylene product manufactured by Matrix Surgical, and our PEEK material, which we can turn around implants within 24 hours. All of these are close to exact fits and best-in-class products. One of the things very unique about the ClearFit, however, is obviously that it's clear, so that when you're placing these implants surgically, you'll actually be able to see the dura through the implant. But post-ops, Longevity, the company that manufactures these for us, has found that you can use ultrasound in the clinic to actually see the critical anatomy. That's led to the development of products such as ClearFit OTS or off the shelf, which can be used for standard craniotomies. In this case, you would place this clear disc inside the actual osteotomy so that you could get the same benefits post-op that you would when using a patient-specific PMMA implant. Longevity continues to innovate, and many of you attended the March training seminar that we hosted down at UMH, where we talked about the Envisishun, and we actually did a lab in which we placed some of these implants in the cadaver setting. Many of the residents were extremely impressed, and we continue to see this product make an impact in people's lives throughout the country. At OsteoMed, we're going to continue to design and engineer novel products. Some of the other ones we have in our portfolio now are the DuraKnife, the SmartFlex, which are pediatric cranial springs, and we have so much more in the pipeline. But for now, we just would like to thank you all for everything that you do and ask you to please stay safe.
This is not just a patient. This is a mom wanting to make it to her son's next birthday. This is not just an OR. This is where years of surgical training impacts lives. This is not just a drill. It's advancing surgical possibilities. Introducing the Midas Rex MR8 high-speed drill system. Featuring efficient technology, a cylindrical magnet, and a compact coil. With controlled precision, versatile access, plus more procedural options and flexibility than ever before. Midas Rex MR8. It's not just a drill, it's advancing surgical possibilities.
Surgical site and offer expanded procedural applications, seamlessly customizing your experience to advance surgical possibilities. The new Midas Rex MR8 drill platform includes 7 new motors, 66 new attachments, tubes, and drivers, 478 dissecting tools, 59 Midas Rex MR8 clear view tools, and is integrated with your S8 navigation system. For over 50 years, our Midas Rex platform has been the name in surgical drills. Like you, we don't rest on our past. We build upon it. That's because we innovate while others imitate. We continue to be the leader in reliability, performance, and surgeon preference. The Midas Rex MR8 high-speed drill system has a lower operating temperature, less chatter, improved visibility of the surgical site, and even better cutting performance. Navigable with StealthStation S8, it seamlessly integrates with our other technologies in our portfolio. Our new Midas Rex MR8 Clearview tools have a variety of shapes, lengths, and cutting geometries for various applications. This includes cranial, ENT, and spine. Precision you can feel. Responsive, comfortable, and efficient. Our latest drill technology delivers smooth, precise bone-cutting performance with a lightweight, compact handpiece design, so you can be confident during your procedures. Our wide range of attachments have been redesigned to provide a more streamlined profile with flexible options you can tailor, so you have improved visualization and increased accessibility of the surgical site. With the MR8 navigated Midas, there are a total of 22 supported dissecting tools. With our comprehensive support, education, training, and service, you have a partner that's there for you from start to finish. Midas Rex MR8. It's not just a drill, it's advancing surgical possibilities. My name is Alex Valeris, and I am your local Medtronic Midas Rex representative. Please feel free to contact me with any questions you may have. Thank you, and I appreciate your time.